Bismillahir Rahmanir Rahim. Dear students, inshallah, today we are going to talk about anticholinesterases as a continuum to our previous talks about parasympathetic nervous system pharmacology. First, we'll talk about their classification, then actions and uses, and we'll end up by talking about organophosphate poisoning and its treatment. Classification. Anticholinesterase, also known as cholinesterase inhibitor. Remember this enzyme, cholinesterase, is the enzyme that breaks down acetylcholine into choline and acetyl-CoA or acetic acid. And these drugs, they inhibit the cholinesterase enzyme. Okay, they are called cholinesterase inhibitors or anticholinesterase. They are divided according to the nature of their binding to the cholinesterase enzyme. If they bind and dissociate, they are called reversible. But if they bind and they do not dissociate, they are called irreversible. Reversible, we can use them as medications. Irreversible are poison. They are very long-acting. These are short-acting. Reversible cholinesterase inhibitors are further subdivided into carbamates and acridine. Carbamates include the stigmines, okay, new stigmine. The suffix will help you definitely with remembering the names of these drugs and their pharmacological actions. Makes it easy. It decreases the list of the medications you need to remember. New stigmine, pyridostigmine, hydrophonium, I made them in yellow to make them different from the white ones. These are quaternary ammonium compound drugs that do not pass through the lipid membrane. They cannot cross the blood-brain barrier. They cannot cross the conjunctival membrane, and so forth. And physostigmine, rivastigmine, donepezil, and tacrine. These are tertiary amines. They can pass through these lipid membranes or lipid barriers. The second class, the irreversible, would say these are poisons. These are, they could be used as insecticides or nerve gases. They are further subdivided into organophosphates and carbamates. Organophosphates include parathione, malathione. Again, this suffix can help you a little bit. And serine gas, tapone, all of these nerve gases used for warfare. And carbamates include propoxur. This is available in the stores under the brand name Bagon. Okay, so let's first, I'm not asking you to remember or memorize the structures, but again, I would like to highlight. So this functions that depends on their amine group. Here, these three drugs, new stigmine, pyridostigmine, hydrophonium, highlighted in yellow in the previous slide. These are quaternary ammonium compounds. So you see here nitrogen is surrounded by 1, 2, 3, 4 bonds. 1, 2, 3, 4 bonds. Here inside the benzene ring or this ring, there is here 2 bonds and 1 bond, so 3. There is no need for more. If you add more, there will be a positive charge. Sorry. The others are tertiary amines. Okay, so these are the physostigmine. You see here only 3 bonds around the nitrogen. Okay, physostigmine, rivastigmine, donepezil, tacrine, and galantamine. All of these could be used if you need CNS action, if you need to use them in ophthalmology, any center action, you can use them. They would be very helpful in these actions. These guys will be helpful in using them for peripheral action. Okay, first we'll start with the the broad idea about the anticholinesterases. Okay, generally speaking, if you need to activate the muscarinic receptors, you are going to use muscarinic agonists. If you need to activate nicotinic receptors, you need to use muscarinic nicotinic agonists. The other way to do that is by using cholinesterase inhibitors. You inhibit the breakdown of acetylcholine, then acetylcholine itself will do the job. It will bind to the both. Please remember, both muscarinic and the nicotinic receptors. Okay, this is actually the idea and the mechanism of action of these cholinesterase inhibitors. Okay, they mimic the effect of combined muscarinic and nicotinic agonists. But please, please, please remember, they don't directly stimulate the muscarinic or nicotinic receptors. So they are parasympathomimetics, they are cholinomimetics, but they are indirect. They don't activate the receptors. They don't activate muscarinic or nicotinic receptors. They inhibit the cholinesterase enzyme, the enzyme that should have broken down acetylcholine. So acetylcholine will build up at the receptors and then will activate both muscarinic and nicotinic receptors. So we cannot say they are muscarinic or nicotinic agonists. They are not agonists. They are indirectly acting parasympathomimetics. Okay. So again, they are subdivided into reversible according to the binding. Here they bind dissociate, or irreversible, they bind and don't dissociate. Reversible, okay, they are short acting. They bind acetylcholinesterase enzyme reversibly. They include, as we mentioned before, physostigmine, rivastigmine, donepezil, tacrine. Okay, they are tertiary amine. Then they can enter the central nervous system. And the quaternary amines, neostigmine, pyridostigmine, hydrophonium, that do not enter the central nervous system. So this is the value of knowing whether these compounds are quaternary ammonium or they are tertiary amines. So their uses, number one, in ophthalmology. If you need ophthalmology, use them in ophthalmology, you need to use what? Quaternary or tertiary? Use tertiary amine because they need to pass through the conjunctival membrane. Yes. So they are used in treatment of glaucoma. Again, just as a reminder, we said in treatment of glaucoma, we would like to use parasympathomimetics and or sympatholytics, specifically beta blockers like timolol. We talked about the direct acting parasympathetic or parasympathomimetic drug pilocarpine before, and today we're going to talk about physostigmine, which is indirect acting parasympathomimetic. And then also physostigmine could be used to counteract the effect of mediatics, which like atropine could be used for refraction testing. So to antagonize the effect of atropine or to bring the vision back, we can use these myotic drugs, physostigmine, to reverse the action or stop the action of atropine specifically because long acting. There are others that have been developed like cyclopentolate, tropicamide. We'll talk about them later, inshallah. Okay, then in Alzheimer's disease. Okay, Alzheimer's disease is characterized by marked decrease in chat and loss of cholinergic neurons in the brain, leading to learning and memory deficits. Okay, chat, what's the chat? Are we going to talk about WhatsApp or Instagram or whatever? No, the chat, you remember? Okay, it stands for choline acetyltransferase. Use my laser pointer. Choline acetyltransferase. It's the enzyme that builds up acetylcholine. Please remember, you always get confused with these two enzymes. This is cholinesterase. Esterase. Ase means the enzyme. Ester means this enzyme breaks down ester bond. So there is a breaking here, right? Whereas here it's acetyltransferase, choline acetyltransferase. So this one transfers acetyl-CoA moiety into choline and builds up or synthesizes acetylcholine. Okay, so please remember, choline acetyltransferase is the enzyme that synthesizes acetylcholine. Cholinesterase is the enzyme that breaks down acetylcholine. Examples of drugs, as you expect, here these drugs need to pass through the blood-brain barrier. So they need to be tertiary amine. We talked about before, rivastigmine, tacrine, donepezil, and galantamine. We said these are tertiary amine. They can pass through the blood-brain barrier. Okay, they block the degeneration or the breakdown of acetylcholine and increase its level in the synaptic clefts, and then counteract this deficit of cholinergic effects or cholinergic neurons. Okay, so third use is treatment of curare poisoning. Curare is arrowhead alkaloids. Okay, they can cause a neuromuscular blocker effect or muscle paralysis. Okay, to deal with them, so these curare, they block the NM nicotinic receptor. NM nicotinic receptor. Okay, they are competitive inhibitors. Okay, but when you use them for treatment, you precede them with atropine to block the muscarinic effects. Why do we do that? Okay, let me start. Neostigmine, indirect acting, parasympathomimetic, it will finally increase the amount of acetylcholine, which can activate both muscarinic and the nicotinic receptors. Okay, do you need here any nicotinic or any muscarinic effect? No, you need nicotinic effect. You need to regain the muscle contraction, right? So you need something to activate NM receptor. So you don't need the muscarinic effect. That's why you block the muscarinic effect with atropine. You enjoy it? You love it? I love it too. Okay, so again, neostigmine activates, finally results in activation of muscarinic and the nicotinic receptors. You need to block the muscarinic effect and allow the nicotinic effect to prevail. So now this can reverse the effect of tuberculin. Tuberculin is competitive neuromuscular block, so it competes with acetylcholine for the NM nicotinic receptor. So whoever is more will prevail, right? Now you are increasing acetylcholine, which will kick away this guy, tuberculin, whatever curare, pancuronium, all other curare alkaloids. And similar drugs like cobra, neurotoxins, whatever, it will kick it out from the receptor, and then acetylcholine will bind, and you can regain the muscle contraction. Then you can use them for paralytic ileus, paralysis in the intestine, or urinary retention to stimulate the motor activity of the small intestine, because again it's parasympathomimetic, right? And this effect is peripheral, so you use neostigmine, which is quaternary ammonium compound, does not pass through the blood-brain barrier. You don't need the central effect of neostigmine, you need only the peripheral effect. Here also the same, use also neostigmine, don't use physostigmine. You need only the peripheral effect. So here it will stimulate the peristaltic movement of the GIT and can improve this symptom in patients with paralytic ileus. It's also used in atony, treating atony of the detrusor muscle of the urinary bladder, again because it's parasympathomimetic, it will activate or stimulate the urinary bladder wall, so there will be contraction, and then you deal with this issue. Okay, dealing with atropine poisoning or belladonna poisoning, the datura poisoning. The belladonna and the datura are the trees from which the atropine could be extracted. So either this or this will be the same. You deal with them the same way. Here use physostigmine. Okay, because atropine has both peripheral and central effects. So here you don't use neostigmine. Neostigmine does not have central effects, will not block atropine central effects. Okay, it will. You can use physostigmine because physostigmine can pass through the blood-brain barrier and can counteract the atropine effect on the central nervous system. Okay, atropine or any other anticholinergic drugs like these class of drugs, antidepressant, phenothiazine, antihistaminic, any drug that have anticholinergic effect. Okay. Then for treatment of myasthenia gravis. Myasthenia gravis is a neuromuscular disease characterized by weakness and marked fatigability of skeletal muscle. It's autoimmune disease resulting from development of autoantibodies against the nicotinic receptor. Okay, so now you need to increase the buildup of acetylcholine at these nicotinic receptors to strengthen the muscle contraction. Do you remember hydrophonium? We said this hydrophonium is one of the three drugs we said they are quaternary ammonium compounds or quaternary ammonium cholinesterase inhibitors specifically. We use this as just for diagnosis. So we need to know whether this patient has myasthenia gravis or just the patient has maybe trauma or tear or whatever. Okay. So use hydrophonium. Why hydrophonium? Because hydrophonium has a very rapid onset of action and short duration of action. Short duration. So you can just give it to the patient, and then if the order is present, hydrophonium will markedly increase the strength. If not, you can try to do more differential diagnosis for the case. Sometimes cause some cramping, but again, it's short acting. This will be done within a few minutes. You use here, again, this is peripheral, right? Or talking about peripheral effect, right? You need something that's quaternary ammonium compound. You can use neostigmine, ambinonium. This is new now. So we have now 4 in the list. We have neostigmine, pyridostigmine, endrophonium from before, and ambinonium. It's long-acting drug. Could be used to improve muscle contraction in patients with myasthenia gravis. Then go to the second class, which are the poisons, the reversible cholinesterase inhibitors, which bind to acetylcholinesterase enzyme irreversibly. They bind, but they do not dissociate. Okay. The examples include organophosphates. They are called also phosphorothioanes. They are long-acting. Okay. They are used as insecticides. They reversibly enhance cholinergic transmission or as usual nicotinic and muscarinic receptors. They are used as poisons, as insecticide by overwhelming the cholinergic circuit because you are building up huge amount of acetylcholine at these receptors, so you are overwhelming the cholinergic circuit in the insect. Many phosphorothioanes, including the examples parathione and malathione, there are 2 processes that goes on. They undergo enzymatic oxidation that activate these drugs or activate these poisons into the more active oxidation products. Like parathione is oxidized into the more soluble, more water-soluble paraoxone. Okay, so this is here. Look here. This sulfur is replaced by oxygen. This will result in great activation of these poisons. Now, a good thing about the difference between the metabolism of these reversible cholinesterase inhibitors in insects and in us and in mammals, generally speaking. There are 2 things. There is the hydrolytic process induced by the carboxysterase enzyme. It is quick. It's very rapid in us. So we can inactivate these drugs quickly. And there is the oxidation metabolism. We just talked about the conversion of parathione into malaoxone, parathione into paraoxone, I'm sorry, and malathione into malaoxone. This results in activation, right? This is slow in us and in mammals, but this is rapid in insects. So again, in insects, they have the hydrolytic process is quite slow, but the activation process is quick. So this can add somewhat to the kind of more selectivity. I'm not saying this absolutely, but they are more selective against insects than us. So if you spray propoxur or whatever, okay, parathione or whatever, to insects, they will be killed instantaneously. But you yourself, you are not going to die except if you inhale a big amount of these poisons. Another example is of these in reversible cholinesterase inhibitors is that sarin gas and taboon, all of these nerve gases used for warfare. Okay, I'm not going to talk about in details in these sarin gas or nerve gases. So now we are done with the reversible cholinesterase. So now contraindication and adverse effects. Please pay attention. I'm talking about here about generally about the drugs, about the medications. I'm talking about the reversible ones. So I'm not going to give the poison to a person, right? So contraindication is don't give them to patients with asthma or coronary obstructive pulmonary disease, urinary or GIT obstruction. The general contraindications for parasympathomimetic drugs, okay, bradycardia, hypotension, because these drugs can elicit or induce these effects. Adverse effects, the excessive sweating, because parasympathomimetics enhance sweating, right? Diarrhea, abdominal cramps, the peristaltic movement, nausea, vomiting, again, the difficulty in visual accommodation because they activate the constrictor pupillary muscle and ciliary muscle. So this will accommodate for near vision, and hypotension because they cause bradycardia and they cause vasodilation. For the organophosphate poisoning, okay, these compounds are easily available. You can buy them from any store, right? These are insecticide. No one will say anything. Okay, it could be used, unfortunately, accidentally. You can get accidental exposure, like you are spraying your plants or your house for flies, insects, whatever. and for suicidal, unfortunately, homicidal, someone killed someone else. Okay, this could happen. This could be the reason for poison. They are volatile, non-polar. Non-polar. If they are non-polar, they are not charged. They are lipids. This will enhance their absorption through mucous membrane and even through the skin. Specifically, if it's even unbroken skin, if it's broken skin, it will be absorption will be much more faster or much faster. Okay, manifestations of poisoning. Again, think about sympathetic activity. Okay, parasympathetic activity. You are increasing parasympathetic activity in a huge manner. They are manifested as muscarinic toxic manifestations, nicotinic toxic manifestations. They activate, right? They indirectly activate muscarinic and nicotinic receptors, and they have CNS effects. Muscarinic toxic manifestations could be abbreviated by these mnemonic dumbbells. Okay, diarrhea, urination, meiosis, bronchoconstriction, bradycardia, emesis, lacrimation, salivation, and sweating, in addition to hypotension. Nicotinic toxic manifestations include fasciculations of skeletal muscles, which can lead to paralysis. Fasciculations or muscle twitch is involuntary muscle movement. Okay. CNS toxic manifestations include restlessness, tremors, convulsion, ataxia, respiratory arrest, which could lead to death. Okay. How do you deal with this poisoning? Number one, you prevent further exposure of the patient to the poison, right? You expose the patient to fresh air, take them outside if he's inside the home, fresh air, remove contaminated clothes, because we just said they could be easily absorbed from the skin, right? Wash the skin and the mucous membranes with huge amount of water to take away all remaining poisons or insecticides. Do gastric lavage with activated charcoal. Hopefully, it can absorb these insecticides on its surface. Then maintain patent airway. So you need to start mechanically assisted pulmonary ventilation. Supporting measures include maintaining blood pressure and hydration and control of convulsions. Antidotes, use two antidotes, atropine and cholinesterase reactivators. Atropine, you see here, we used the cholinesterase inhibitors for atropine poisoning, right? Remember atropine poisoning, belladonna poisoning, nitrosamium poisoning, right? They also are kind of doing the opposite. You can use them as antidotes or use atropine, antidote for these drugs. So all cases of anticholinesterase enzyme poisoning, inhibitor poisoning, must be promptly given atropine. Give atropine, it's the number one. Highly effective in counteracting the muscarinic symptoms. Okay, generally they are the peripheral one, but higher amount needs to be antagonized the central effects. You need higher amount to antagonize because the cholinesterase inhibitors they have central and they have peripheral side effects. They don't reverse peripheral muscle paralysis, which is nicotinic, because atropine, as you know, is selective muscarinic antagonist. The second class of drugs is the cholinesterase reactivators to restore the neuromuscular transmission. So now cholinesterase enzyme was inhibited, right? You just rejuvenate, reactivate this enzyme, okay, by using these oximes, including pralidoxime and metoxime. They relieve the nicotinic effect, including muscle weakness, twitching, respiratory depression, and muscarinic effect of organophosphate compound poisoning. Treatment should be started as early as possible, within 1 day to 2 days. Atropine actually is number one, followed by these oxime in treatment of organophosphate poisoning. I'm done for today. I hope you enjoyed this class, and please always enjoy and say Alhamdulillah Rabbil Alameen. Wassalamu alaikum wa rahmatullahi